Welcome to Senior Talk with Ms. Bonnie, where each episode we explore the joys and challenges of aging. Join Ms. Bonnie as she talks with experts, seniors, and caregivers about topics that matter to the senior community. From health and wellness, to relationships and family, to finances and social engagement, we'll cover it all. This episode, Ms. Bonnie sits down with Gwendolyn Fischer and Dajine Adamson, both registered nurses, as they discuss home health care. So whether you're a senior yourself or just want to understand and support the older adults in your life, you're in the right place. I'm producer Chuck, and without further ado, Senior Talk with Ms. Bonnie.
Okay. Hi, everybody. My name is Bonnie Angie. Welcome to Senior Talk with Miss Bonnie. I forgot to do my introduction. I just dove right into this because I think it's important for us to know also you have all the intentions in the world of taking care of your parents, doing the right thing, being there for them. And sometimes you just can't. You can't be there. You can't be all of everything to everybody, you know.
Yeah, and then also you gotta have a certain skill level.
That's true.
It's not like paying their bills or going to the grocery store for them.
Okay.
This is medical. This is, you know, like
life-sustaining.
You give the wrong
stuff.
pill at the wrong time, and it's a downward. It's kind of a downward spiral. It can get out of control or fall.
Or a fall.
Yeah.
Oh my. Which we, you know, and I'm ambulatory, but when I fell, now I know what they mean.
Yeah.
It's like when a baby falls, he springs right up.
Mm-hmm.
When you fall, and if you hit it the wrong way, you're there.
Yeah.
And lo and behold, if you're alone.
Yeah.
You know,
Yeah.
so,
yeah. I mean, and it's a real deal. Like,
yeah.
was talking to my cousin,
Mm-hmm.
and he's in that position now with his mother. Mm-hmm. And he brought up something incredible that I'd never even thought about, which was it's a line between child and parent that has to do with like decorum. Mm-hmm. And when the child is the caregiver, then those lines go away because you're going to see your parents in all these vulnerable positions.
Yeah.
And you know, it's a certain level. You got to be cut from a certain kind of cloth.
Exactly.
To be able to.
It's like with your grandma. We went from a strong, vibrant, do-it-yourself woman to she was sick, just plain sick. Yeah. And after a while, you can't do it because, number one, they don't want to be sick. That's number one. And number two, they don't want you taking care of them. Because my mother would always say, although my sister was a nurse, she would always say, I want her to take care of me, you know, because she's too, you know, she may be too, you know. It's hard to take care of your parents. And then when the roles reverse, and I can see a little bit that now with us just working together, he gets his digs in, so he gets an opportunity.
I do not get digs in.
Oh, yeah, you do.
No, I don't.
You know, that producer's revenge.
That's no.
But anyhow, it's hard for a child to take care of their parents, so that's where home health comes in.
Right.
And what we're going to do, what we're talking about today with Gwendolyn Fischer, my sister, retired BSN, and Dajine Adamson, my granddaughter, who is a traveling nurse, and an RN traveling nurse. And they're going to discuss, from a medical standpoint, the advantages of hiring or home health people. And also when you're having home health visitors and you live out of state or you are busy, or you're starting a new company or something like that, there's a person visiting your mom or your dad every day or every other day, or enough for them to feel comfortable and not alone until you can get there. And so the home health person has many feathers in their hats, I think.
Yeah, it's a lot to juggle.
It's a lot.
Yeah.
You know. So, without further ado, I don't have much more to say about that because
Well, this episode they're gonna go into what to expect
Right.
from a good home health
Right.
care.
And what to look for.
What to look for, right?
In a good home health
Yeah.
person.
And just kind of what
You know.
what they will do, what they won't do. So if you're ever in that situation, you have an idea what kind of questions to ask
Right.
and what kind of expectations to
Right.
have.
Right.
And that's the goal of this episode.
Mm-hmm. Even at my young age of 73, I've been asked I just switched over to the new doctor, and the first thing she asked me, are you having home health services? No. You do your own cleaning? Yes. You do your own cooking? Yes. You're able to bathe yourself comfortably? Yes. Do you do your own exercises without any help? Yes. So a lot of that. But who's to say when I come home and my day is settled, I'm able to take care of myself going forward. You know, you're in pain sometimes, you know, or you get confused on your medications sometimes. Sometimes you don't need it to clean your house and wash your clothes. You need them to help you with that medication. Mm-hmm. My sister was on, oh my gosh, at least 17 pills. Okay, that's a lot of pills. And some was daytime, some was nighttime. Break this one in half. That's a lot. But her daughter was able to step in there. And then when the nursing service came, they never had a home health care because she really didn't want nobody there to do that part of the work. Because I guess that's why I was around. But and I enjoyed every minute of it. But that nurse, he came 3 times a week. And she looked forward to him coming 3 times a week. You know, although she had a daughter there and grandchildren there, she was still looking forward to talking to that nurse that came.
That professional. She can ask those questions and get that anxiety off.
Right.
Or
she could complain without them saying, oh, Mom. You know, so. But anyhow, without further ado, I'd like to introduce you to Gwendolyn Fischer and Dajine Adamson. And I hope we've covered and will be able to cover any of your questions. If you have any questions, you can always put it in
the comment
section.
Yep.
Okay? Thank you so very much.
And while you're in the comment section, like, subscribe, follow. And share.
Yeah, that too. Hey, everybody. My name is Bonnie Agee. Welcome to Senior Talk with Miss Bonnie. Today we're going to discuss home health care. I have 2 ladies with me, 2 women with me. One's Gwendolyn Fischer, the other one is Dajine Adamson. Gwendolyn Fischer is BSN retired. Dajine Adamson is RN active. Gwen is my sister and Dajine is my granddaughter. And I'm very pleased to have both of them here to walk through this with me. We have been talking a little bit earlier about certification, the people they hire, the people, the facilities. So we're going to take this one step at a time and get their input. Gwen from back in the day, because she's been retired now for
ever since 2014.
2014. And Dajine is still lives in Roanoke, Virginia, while Gwen is here with us here in Columbus, Ohio. So there's going to be some differences simply because of the states. But the bottom line is still the same. Good home health care, which is really, really hard to find. I live in a senior building, and I have seen things that
curl your
unbelievable.
Hair. Mm-hmm.
They steal little things. Mm-hmm. But nobody tells you when they have a good home health care person. They don't tell you that. I guess they don't want to lose it to another person, too.
Yeah, that's a lot of it.
Yeah. But I've seen things, they take the either the bottom sheet and give them the 2 pillowcases and the top sheet. Simple things. It don't mean nothing to a person that does their own laundry, but to a person that's depending on somebody to do their laundry for them. They depend on them to bring them back what they send, but because they're sick or they're old, who do they have to complain to? Mm-hmm. Mm-hmm. So, Gwen, would you like to introduce yourself some more?
My name is Gwen Fischer, and I've been RN for I was an active RN for almost 40 years. And of course, I too have seen a lot of things that have happened in the field. But home health, I remember once I started, I was the training nurse for the CNAs, the certified nurse aides, to kind of let them know they had to go through a complete program. We had tests and quiz and just everything. And then they had to pass the state test. So it worked out pretty well, and I did enjoy it. But there's a lot that people should look for. The first thing is compatibility. Is this person compatible with your family, who's going to be in your home taking care of either A, your loved one, or B, yourself? Are they following the instructions? Every home health case is opened up by an RN, and that RN determines what is needed in that home by the certified, what the certified nurse, nursing aide should do. The RN does that. Now, if there are other services that are needed, such as physical therapy, occupational therapy, speech therapy, those have their own assessment, and then those are taken care of by each department. But the bottom line is compatibility, that they follow your rules, the rules and regulations of whatever authority have put down at that time. The nurse is over the aide, and she puts down a care plan. So the family should be aware of what the care plan is. She should go over that with the family as well as the patient, and everyone should agree with it. And she will also go over it with the aide, and that should be followed through. If it's not, then there are people in the agency that they can talk to, such as the head nurse, the case manager, or the owner of the agency. There are steps to go, and if they don't find satisfaction, there's always a state agency they can go to. There is a lot to it, I know, but I still stick with compatibility. You have to be part of and comfortable with the person that's taking care of you.
Okay.
Yeah.
Dajine, how do you prioritize and manage? You don't do home health care now.
Yes,
You do it.
I do.
Well, why didn't I think you didn't do it?
I don't know, but I do. I've been probably because I switched jobs so much.
It might have a little to do with it.
But I've been with the company that I'm with for about 6 months, and we do home health. So I am a home health RN. So yes, what was your question?
Let me finish my question
Okay.
then. Okay. How do you prioritize and manage your task when providing care for multiple patients in their home, husband and wife?
Okay. So with my agency, it's a lot like Dedicated, which you've talked about on the podcast before. We're kind of all-inclusive. I listen. We're all-inclusive. We're the medical provider. We provide therapy. We provide home health care services. We're their insurance provider. But we don't have a lot of couples that we see. So if we see somebody in the home, it's usually one spouse or the other. Or we even have like parent-child dynamics of participants that we see. And we call them participants instead of patients or clients because they are expected to participate in their own healthcare just kind of across the board. But in the cases that we do have multiple people in the home getting home care, our home care services are individualized. So whatever the husband would need, we would go in and we would do that. And then we would do whatever the wife would need. Our acuity or the amount of care that the person requires usually isn't high for our home health participants. So there's not really that burden of trying to prioritize, okay, you're going to go in here. Mr. John needs his central line dressing changed. He needs, antibiotics ran through that, while Mrs. Jones just needs her medications checked. So we don't really have a lot of that. For our company, as the RNs, a fun fact, I work with my mom. She's the other home care RN. So we just go in, we do a lot of medication checks to make sure that our participants are taking their medications as prescribed. We do a lot of medication education. and we do discharge visits. That's mostly what we do as far as our home care services. If they need a higher acuity, like they have those IV antibiotic lines or catheters or whatever else, those are typically handled either by the clinic that we have in our in our company, or they're in assisted living or a nursing home, and they wouldn't get home care services if they're in a nursing home.
Okay. Very interesting. Keeps you busy, huh?
Yeah. Yeah.
What strategies do you employ to ensure safety and well-being of your patients in a home health care setting? Now, although Gwen is done with this in the past, I was wondering if things ever change. When you give an answer, Gwen, you can tell me, well, it hasn't changed in the past 15, 20 years, you see. Or it has a lot, so
we were talking earlier about you have to give your CNAs, and this is everywhere, you have to give your CNAs specific tasks with specific instructions for specific participants. That's just across the board with nursing. But what we do is we have a form called a participant service plan, or a PSP, and it's individualized to each participant. So it's got their information, it's got anything that we need to know about the home, any pets, any if they live alone, if they live with somebody, what kind of shared areas they have, because if they do share areas, we can only do for our participant.
Now, wouldn't that be a little odd? It would be like being in a hospital with just a curtain between you and wouldn't that be odd? It's
never been an issue, and like I said, we only usually serve one person in the house, and that's because that person can't do for themselves. So with those participants, we usually don't go in and do a lot but showering. So our home care services, our CNAs, our CNAs can do housekeeping, so they can do sweeping, mopping, vacuuming, some light dusting. They can do meal prep with the microwave. They can do laundry for the participant. They can do dishes, make the bed, shower, bathroom cleaning, all that stuff. They don't go into any shared, well, I won't say they don't go into any shared areas, but they don't do the housekeeping for the shared areas. So if a person lives with their spouse or their child, it's expected of the spouse or the child to do the housekeeping in the home. If they
I see what you're saying.
If they want laundry done, then it's the participants' clothes should be separated so that the CNA is only doing the laundry. If they have their own room, the CNA can bring out dishes and wash the dishes that they took from the room. But if there are dishes already in the sink, the CNA doesn't touch those. So it's just kind of making sure that we're not doing, because it's a liability thing. We don't want anybody to be able to come back and say, oh, CNA did this for the husband and now his shirt is messed up. CNA shouldn't have been washing his shirt in the first place. So that's part of the participation and part of the home care contract that they sign, is that things are only done for the participant. But all of the services that each participant gets are on that PSP, or that participant service plan. And you go through its checklist of everything that the CNA is expected to do. And like I was saying earlier, to ensure safety in the home, everybody is a fall risk that we serve. We serve seniors, individuals over 55. A lot of them have dementia or Parkinson's or decreased mobility, so everybody's a fall risk. So in that PSP, it's always checked that they're a fall risk. And there's always a note that says remove clutter and clear pathways, so that when the CNA goes in and there's mess everywhere, they are expected to make sure that the participant can get to where they need to go safely. Our OT also does a lot of that, going in and rearranging, adding ramps, doing education with that. The nurses will reinforce the education and make sure it's done.
So you said OT. What's an OT?
Occupational therapy.
What do they do? What's their role?
They are, they deal with what's called activities of daily living. So they assist the participant in managing their getting in and out of bed, showering, toileting, getting in and out of the home, whereas PT works on the kind of the larger muscle groups or individualized to specifically mobility. The OT kind of helps them manage everyday tasks.
Gwen, does that sound pretty much like what you did in the past?
It's exactly the same thing. That hasn't changed. But what she calls a PSP, I believe, we call it a care plan.
Yeah, we have care plans too. We and our PSPs are also integrated into the care plan.
It's the same function. It's just I get tickled because it's a
and I think
different name.
PSPs are, I think, more specific to our
to
our company, and it's just a kind of further step to, because the CNAs don't see the care plan.
How do you communicate and collaborate with the patient's family, physician, and other healthcare providers to ensure coordinated care? Let's just say, for instance, for the layman, I needed it, but I don't want to do nothing if my doctor ain't said to do this. How do I know for sure that either one of you have made sure? Is that what your company do, or is that what you do in front of them, or in order to make them feel secure, comfortable, and it's okay to, we're going to switch this up a little bit, not changing medication or anything, but just certain things, instead of us using, let's say, a bandage that they've been used to use, we're going to use a non-stick bandage, and they're used to the one that's, waiting on it to hurt to pull it, that type stuff. So do you do this on your own, or do you have to have written permission, everything you should be able to show the patient? Or
Basically, you have to have written permission for everything you do to the patient and for the patient. In your scenario, I would first, if the person voices that concern to, say, the CNA that's there, then she in turn would let the nurse in charge of that patient know about it. And then that nurse would handle it from there. She would she would find out exactly what the patient concern is. Because sometimes they'll ask you a question, but they're really asking something else altogether different. So you find out what the concern is. Then you go, if it's a legitimate concern and you can do something about it, then you will ask the doctor in front of the patient, or you will say, I will send a message to the physician to find out exactly what he wants us to do about this. And then you'll get back with the patient within a reasonable amount of time, so that there's no concern or anything.
Right. So the fact that they could go, so in other words, there's no room left to tell a family member, well, the nurse just did it.
Right. And like you were saying, as far as coordinating care, we're all inclusive at my company. So our doctors work out of, it's a doctor and 2 nurse practitioners. They are the participants' primary caregiver. So once they enroll in our program, they don't see their former primary care provider.
I see.
So the provider there takes over the care and does any medication adjustments, anything like that. Mm-hmm. So
but what happens if that particular patient has been with that particular doctor?
Then they have a decision to make whether they're going to enroll in our program.
So your program is more like the one dedicated that Bonnie.
It's a lot like it, yeah.
See, I never was in. That's a new phenomenon. Okay,
and
that's a new one.
It's to kind of ensure that coordination of care. We do have, so for specialists like podiatry or cardiology or things like that, we have a scheduler who then will schedule out or refer out, and then they would go and we would provide transportation. But any type of appointment that is not approved by our company doesn't get paid for, because we are their insurance as well. You had asked about specifically about changing wound care orders or about the dressing, and I wanted to address that because I think that
is important
to talk about, and how it, I guess now with nursing, the providers are a lot more, I don't want to say lenient or trusting, but we have a little bit more autonomy, especially in the home health care setting, because we're out in the field, we're not in the clinic, to be able to make dressing or wound care order changes as we see necessary. So, for example, if we have a participant who's been seeing and they've been seen for a specific type of dressing, that is, different dressings have different jobs. So if they've been getting a wound care order that says we need to dry out this wound, and the home health care nurse goes and sees that the wound is dry, then we don't keep putting that same bandage on.
I see.
We are able to change that order, change the dressing that has been given, and then we have to go and write the order to give to the provider to sign. So everything still needs an order.
Okay.
So you had mentioned, the nurse isn't just does it. Sometimes we do. It's in our scope of practice to make that judgment call, but we always have to have an order. And a lot of times I've noticed since starting nursing, and I'm not sure how providers felt about it when you were getting started, but a lot of times they'll just be like, okay, change it, write the order, and I'll sign it. So that's something that we do have the autonomy and the wherewithal to do.
Now that sounds like when we used to, if you've been in home health for a while and you've been dealing with a doctor and you and that doctor have a rapport, then he begins to trust your judgment. Then he would do it, oh yeah, go ahead, write the order, I'll sign it. But if it's a new doctor and you're a new person, then it would always
you would have to build that
this
trust.
is how the wound looks, and do you want to try this dressing or shall we try this dressing? You'd offer suggestions with them.
And they always have to be seen by the provider. So once you change that dressing, then you also
can't.
make an appointment with the clinic to
So
have
you
them
have
go
to
in.
call the clinic. See, we would have to call the physician and get an appointment time for that person
So with
so
our
that they could see the wound and how it was looking.
Yeah, so
Right.
with our, and that's why
Right.
we call the clinic, because the clinic has medical assistants who handle the appointment
Things
making.
have changed.
Or we can talk
Yes.
to, we talk to the medical assistant and they'll make the appointment to come in. We have a wound care doctor that comes in on Monday, so all of our participants with wounds come in on Monday to see the wound care doctor and do that. But it depends on the provider and the nurse and the company and the state to kind of.
Well, I think it's the same way. It's just the way when I was doing it, how it's done. But it seems to be basically the same way. You still need that order to do
Always.
the change.
Always.
So it's really how is it the communication?
Exactly.
And you don't
When
go-
you
you don't
communicate.
have to call and wait for the doctor to call you
Right.
back. You can call your person and it's right there, and they say, well, yeah. Or you can take a picture nowadays and send a picture to them. So it just makes it so much more convenient.
Very much.
I like that way. I'm not going back. Y'all have fun.
Now, here we go, ladies. This question, don't y'all fight to answer it, okay? How
We
do you assess and address the social and emotional needs of your patients while providing care in their home? And I know that's got to be tough.
Yeah.
Oh my gosh, what an inhale.
It
So
takes more than one visit.
It does. It does. And it also takes kind of knowing your participants' history medically, their diagnoses, especially their mental health diagnoses. And kind of, it's all about, with home health, it's all about building a rapport with your client, participant, patient, whoever you're seeing. And just making sure they trust you enough to listen to your suggestions. We have a couple of participants who become extremely depressed. They live alone, they're on all these medications, they can't get around like they want to. So the first thing I always do is encourage them to go to the day center. We have like an adult daycare, and I'm putting that in air quotes because, it's kind of a hot topic. You know,
kind of just get them out of the house.
Yeah, and they come
make
in,
them
they
do something, make them
socialize.
move. Yeah.
And they do. We have a whole recreation manager who coordinates events, outings. They go to Walmart all the time. They go out to lunch all the time. So for those participants, my first thing is always, when's the last time you went to the day center? Are you going on your next visit? Why haven't you been going? And then I go into the whole, it's a cycle. You sit in the house by yourself, you become depressed. You become depressed, you don't want to do anything. You don't want to do anything, you don't take your medicine, and then you're falling, and then you're in the hospital, and then you're depressed. So I kind of go down that rabbit hole, and sometimes I probably get on their nerves enough, and they're like,
That means you're doing your job.
I'll be there tomorrow. I'm coming on Wednesday. So it works.
All I can say is that what she's doing through her agency, we had to go outside at the time when we were doing it to find that daycare center. I would have to make other arrangements. You'd have to call. You'd have to coordinate the services. And then it would be transportation. How are they going to get there? So the thing I like about the agency that they're with and what I see happening is that it's all becoming one umbrella. You don't have to go through the different. We had
Hoops.
to go through all kind of hoops just to get a person from the home to the daycare 3 days a week and see if they had a bus that would come in that neighborhood to pick that person up. So I like the
Yeah, we
new
do
way
all
of
that.
doing things.
We're open 5 days a week.
Yeah.
We have the whole we have our own buses, vans, whatever. They'll come get you. They'll take you home.
Well, that's what Bonnie was saying about Dedicate. When she told me, she said, well, they'll send an Uber to get me. I said, an Uber to get you? She said, yeah. I said,
We don't pay for Ubers.
oh.
We got a car. It says our little company name.
But the idea that someone would send an Uber to pick up a patient to come to an appointment, to me was like, wow, has things, things have changed.
Things
and
have
they seem to
changed.
be changing in the right direction. So I am happy to see that.
Yeah. And in conclusion, Dajine, I appreciate you taking the time to do this with me. And Gwen, as always,
You're welcome.
you're my go-to person when I need a second voice, and sometimes even the voice of reason. Now, I want to wrap this up. And until the next time, remember to click on like, comments, and subscribe. Thank you, ladies, very much. I appreciate your participation.